Okay, welcome. If you're watching this screen, we are at the start of our presentation today on the New York Health Act. So welcome to Long Island Activists Virtual Town Hall on the New York Health Act. And we're going to start you off with an overview of the New York Health Act brought to you by the Campaign for New York Health.
There's an epidemic that millions of New Yorkers and people across the country are suffering from, and you may be suffering from it too. It's private insurance-induced stress disorder, PIISD, or PIST. It's a condition brought on when you get a bill in the mail that your health insurance premiums have gone up 20% or more, or when you realize you have a 50% coinsurance even after meeting your deductible of $3,000, or when you don't have insurance at all because you can't afford it. Or when your insurance plan drops your doctor and you have to find a new one. Or after spending countless hours on the phone, arguing and pleading with customer service after you've been denied treatment. It occurs after your bank account has been drained of your life savings to pay for care. Or after seeing a loved one maimed or die from an otherwise manageable illness. But there is a cure, and that is the New York Health Act, guaranteed health care for all of us. The New York Health Act eliminates wasteful private insurance companies and replaces them with one public program that is accountable to us, the people. We can have an improved Medicare for All-like plan for New Yorkers. Healthcare that covers everyone as a right, as a public good, not as a commodity to be bought and sold on the marketplace. The New York Health Act would cover all medically necessary care, including vision, dental, mental health, reproductive health, prescriptions, and long-term care. 98% of New Yorkers would save money on healthcare. It would be funded fairly with a progressive tax based on your ability to pay, instead of forcing people to pay as much as possible and go bankrupt in order to get life-saving treatment. It will restore decision-making to the doctor and the patient, not the insurance company bureaucrat. The New York Health Act has passed the Assembly 3 times with huge majority support in the last 3 years. We only need one more senator to have the majority of the state Senate. How are we going to get across the finish line and make this a reality? You. We know the opposition is formidable. They have serious power and money. But we have the people. We need to win universal health care so that everyone can have the peace of mind that they and their loved ones, their neighbors, and their employees get the health care they need when they need it, without fear of going bankrupt. Join the fight and make sure that New York does the right thing. Call your state senator today. Tell them to support the New York Health Act, guaranteed health care for all of us. Sign up at nyhcampaign.org.
So today's event is going to be moderated by myself and by my colleague, Mariana Pineda. Just a little bit of background about myself. This is my first term as a steering committee member of Long Island Activists. It actually is the end of my first year. And I've been driven to activism all my life. I don't want to really get into my whole life story. It'll be a long one. A good one, but a long one. But currently I'm a history teacher at Locust Valley High School. Been teaching history for about 27 years. Activism is in my blood, and I'm so happy we're able to have this presentation today. Mariana, are you with us at present? I'm not so sure if you're on right now. So I'm going to assume she hasn't logged in as of yet. I don't really know. So a little bit background about Mariana. Mariana also is a school teacher like myself. She teaches special education in Roosevelt School District, and she's very much an activist, and she's involved in this organization very actively, as well as many other organizations. And I know New York Health Act is very close to her heart. And when she does log in, oh, there she is.
Here, I'm here.
Take over. Introduce yourself.
Are we starting? Are we live?
We are live, yes.
Oh, well, holy shit. Hey, everybody. Oh, no, I promised I wasn't going to curse. Hi, my name is Mariana Pineda. I am and now outgoing steering committee member for Long Island Activists. And I am grateful for the time that I've had with LIA, but I'm looking forward to focusing more on my work with the Poor People's Campaign, with the Democratic Socialists of America, and with the Campaign for New York Health, because you know, we can't all do everything, but we can each pick one thing and work on it really well. And for me, working on healthcare is my passion because I'm a special education teacher in the Roosevelt Public Schools. And when we talk about healthcare justice, racial justice, immigrant justice, and education justice are all deeply tied in with healthcare justice. When kids get special education services, those are paid through a Medicaid waiver through the schools. You know, a lot of school speech pathologists, PTs, OTs, and other third-party providers are paid through the student's private insurance or federally through Medicaid, and it's not part of the regular school budget, and people don't understand that. Things like students having access to eyeglasses so they can see the board, you know, that's an education justice issue, but it's a healthcare issue. So I'm all about, you know, doing intersectional work through the lens of healthcare and how we can help our documented and undocumented brothers and sisters, how we can help our black and brown brothers and sisters, how we can help our non-English speaking brothers and sisters through the lens of healthcare, but in order to get the same equity and the same access and the same level of care that comfortably middle class, American born, white presenting people take for granted every day. And that's kind of what funds my work. And incidentally, I am COVID positive. I am an immigrant and I am a single parent, but I'm lucky as fuck because I'm a US citizen with a good union job and I have health insurance. And so this May, I can afford to pay my rent, but so many other people can't, which is why also totally not New York Health Act related, but we need to cancel rent. Okay, I'm done with my speech. Hi, everybody.
So we're going to be back to you, Mariana, in a second for the next segment. I'm now going to give you an overview of today's events. We're going to have, in a few minutes, Mariana's going to be back and she's going to actually elaborate a little bit more about her personal story. Followed by another personal story by Jayette Lansbury. And then following that will be another personal story by Susan Carpenter. After the personal stories, we're going to get into the panelists and officially start this presentation. So our panelists for today's virtual town hall on the myths and truths about the New York Health Act are, we have with us the Honorable New York State Senator Gustavo Rivera, who is the co-author of the New York Health Act and its chief sponsor. And we're going to tell you more about his background when we introduce him formally a little bit later on. Followed by that, we're going to have Dr. Martha Livingston talk about what is a single health payer system. She's going to give us a big picture overview. Following Martha Livingston, we're going to have Katie Robbins, who's going to talk about how people's lives will change if we're able to get this important piece of legislation passed. Following that, Dr. Cashin is going to talk about the supply side of things, basically the logistics of how this is all going to work. Specifically, she's going to talk about how single-parent agencies can be strategic in ways that private insurers cannot. And like I said, after that, well, I didn't say that, but after that, Dr. Susan Carpenter, I'm sorry, Miss Susan Carpenter will be back. She, in addition to having a very important personal story, she is the chair of the Long Island Regional Committee of the Poor People's Campaign. So she's going to speak for a bit. After we have our presentations, they're all going to be about 10 to 15 minutes in length. We're going to have a question and answer session that Mariana and I will lead. And after questions and answers, we're going to take up questions from our chat audiences from both Zoom, and we're about to launch right now for Facebook Live, so we're going to be taking in some questions from there. And then Katie Robbins, we're going to go back to Katie to give us some closing thoughts about how we can take what we learned today and act on it and move forward. So that's basically the format of today's presentation. I'm going to go back to full screen. And let's see, we're ready to begin with personal stories. Mariana, you're going to take over.
All right, woo. So am I going first? Hold on, I have the agenda. I'm going first. All right, so I apologize. My brain is a little bit mushy right now. I have been trying for the last week to schedule an appointment with a neurologist. But every time I call, the neurologist's office is closed. And when I call their other location, it just prompts me to leave a message, and I leave messages. And when I call and I ask to speak with the on-call neurologist, I I explain to them all of my symptoms, and they say, well, if that's how you're feeling, you need to go back to the ER. And I've been to the ER 3 times in the last 3 weeks. And it's just so incredibly frustrating when you are very sick, and the system creates all of these unnecessary additional hurdles for you to try to overcome. So for instance, I have a 17-year-old daughter. She is a classified special education student. She not only goes to an alternative school, she goes to the night school program in the alternative school. Um, Unfortunately, my 17-year-old daughter has significant mental health issues, and she also has recently gotten involved with drugs and alcohol. And now she went from being in an outpatient mental health program to an outpatient dual diagnosis program. Because of the COVID pandemic, they stopped having in-person care. So my daughter was unable to physically go to the clinic where she had been going to get her treatment. Um, there are not enough inpatient residential psychiatric facilities on Long Island that are properly staffed and properly funded and safe. When my daughter was at South Oaks, she was sexually assaulted by a fellow female in the mental health hospital. Girls in the mental health hospital were able to smuggle cell phones, smuggle weapons, smuggle drugs, and she didn't get the help she needed. And when she was discharged in a week, because that's what they do, they take you in, they load you up with prescriptions, and then they send you right back out. It's this, that's the mental health system. On Long Island, we don't have enough beds for residential programs, and mental health has such a terrible stigma, and people are embarrassed and ashamed, and they don't ask for help. And so I've been asking for help for my daughter since she was 13 years old. And unfortunately, with the COVID pandemic and the quarantine, she, and having her issues, she had a very difficult time complying with the quarantine. And she would sneak out of the house, and occasionally she would sneak people into the house. And I explained to her that I have, a compromised immune system. I'm asthmatic. I have chronic bronchitis. I've been hospitalized for pneumonia twice previously, independent of COVID. Once when I was a senior in high school with bipulmonary walking pneumonia, where I almost collapsed at school. And once again, when I was teaching in the city, and I nearly collapsed in the hallway, and one of the school safety agents physically caught me, and my administrator encouraged me to go home and get medical care, and I wound up in the hospital with pneumonia. So I always knew in my heart of hearts that if I were to get COVID, it would impact me severely, which is why, even though, knowing the risks that I have, I was still very involved with the mutual aid programs through the Democratic Socialists of America. But, we were safe. We used masks, we used gloves, we exercised social distancing. But as my daughter's untreated psychiatric needs escalated, the risks in my own home escalated. And she became aggressive with me. She physically assaulted me. And like the case manager can't come do home visits anymore because of the pandemic. And eventually I had to call 911 because unfortunately on Long Island, if you want an ambulance, you never get just an ambulance. You get ambulance and police and sometimes fire trucks, and completely unnecessary. There's no fire. Don't waste taxpayer resources. Don't send a fucking fire truck. And when it's a mental health or a substance abuse issue and you need medical help, the last thing you need is police, okay? And the police came and they were very aggressive with my daughter. She's 17, and they were cursing at her and they were dragging her on the ground. And I had to physically get in between the police officer and my daughter and take out my phone and start recording. And I said, she's a kid and she's sick and we need to help her. And, they said, well, what do you want? And I said, well, look at her. She can't walk. She can't talk. The things that she does say are complete nonsense. And she's being aggressive, but she's not a bad person. She's not, I'm not taking any of this personally. It's the illness, and our system is not designed to provide adequate mental health care and adequate substance abuse care. And it's heartbreaking as a parent because you want to help your child. So eventually, when the paramedics arrived, they treated my daughter as a human being and not as a fucking, savage animal or a criminal. And they were able to get her on the ambulance, and they told me to follow the ambulance, and I did. We went to Good Samaritan Hospital, and I spent over 10 hours 3 weeks ago in the emergency room of Good Samaritan with my daughter and the one-to-one that had to restrain her. And at the end, they said, all right, it was, it was drug and alcohol overdose. There's no medical treatment. Once she got rehydrated with the IV and once she slept it off, they were like, all right, we're going to discharge her. And I said, how can you discharge her? I don't feel safe. And they said, well, there's no options right now. No programs are going to take inpatient mental health patients right now unless they're an active danger to themselves or to each other. And once she slept it off, they asked her if she wanted to kill herself, and she said no. And they asked her if she they asked me like, had she assaulted me with a weapon, and no, she ripped my shirt with her hands. But I still felt unsafe. But they said, I'm sorry, and they discharged her. And while I spent 10 hours in that packed, overflowing emergency room, I watched two people, both people of color, die from COVID. And while I sat there, I saw people who do not speak English, who were not getting the assistance that they needed because there were not enough Spanish-speaking staff. So even though I was there dealing with my daughter, I was also walking around the ER providing translation services for other patients because they didn't have Spanish-speaking staff in the ER to help people. And that's a huge issue in our healthcare system, is language access. Because yes, single payer is wonderful, and yes, everybody should have coverage and everybody should have access. But if we don't have people who speak the language of the patients or some kind of intermediary system for those patients to communicate, when the doctor was telling the man that he needed to lay on his stomach and the man kept saying he was in pain and he wanted to lay on his back and they couldn't talk to each other, that man is not going to get relief. That doctor is going to feel frustrated, and it shouldn't take another person who just happens to be in the ER by happenstance to do that. And I'm going to speed it up because I know we're short on time, but what happened was, I believe that in that ER is where I got infected with COVID, because even though I brought in my own little paper mask, and I don't even know where it is right now, but I was wearing a little paper mask like the same kind I would wear when I would go to the supermarket. Those masks are more for the protection of the people around us. Like if we have germs, they're going to keep our germs in. They're not going to keep other people's germs out necessarily. That's why, doctors and nurses need proper respirators, and, our government failed exceptionally on that. But I believe that in those 10 hours at the ER is when I got it, because there were COVID positive patients less than 6 feet away from me. There was an elderly African-American man who died less than 6 feet away from me. And just the emotional trauma alone of this pandemic is a whole nother, episode. But I believe that that's where I got sick. I started to lose my smell and my taste, and I started to feel like generally unwell. But I was like, maybe it's a cold, maybe it's seasonal allergies, maybe it's just that my lungs are crap because I'm asthmatic. And the first thing I did was try to refill my inhaler, but my pharmacy was closed because of COVID. So I had to get my prescription transferred to another pharmacy, and then I had somebody come, go into the pharmacy and pick up my prescription, drop it off for me. And I used my asthma inhaler, and it wasn't enough. So then I dug out my nebulizer, which I usually only need in the winter, and this winter was a pretty mild winter, so I didn't even need it. So I dug it out, and I couldn't find the mouthpiece. So I had to put on Facebook, mutual aid request. Does anybody have the diffuser and the mouthpiece for a nebulizer? And somebody came through, more mutual aid. My former Girl Scout troop leader, she showed up at my house and she dropped off the nebulizer on my doorstep. I did it. I threw in some albuterol, and because my lungs on Saturday, like we went to the ER on Wednesday, and on Saturday I felt like my lungs were slowly filling with wet cement. Like there's no other way to describe the feeling. And then Sunday was Easter. And even though I didn't interact with my toddler son because I had a feeling I was sick and I didn't want to expose him, I just watched him, collect Easter eggs on my front lawn. Sunday was a pretty good day. And then Monday came, and Monday I felt like I was underwater. Monday I felt like I couldn't breathe. And as a person with asthma, I know that feeling. And as a person who's been hospitalized with pneumonia, I know that feeling. And I knew that I needed help. There have been times in my past where, I was between jobs or starting a new job and I didn't have health insurance and I did not go to the ER and I did not go to urgent care. And I wrote it out, on my bathroom floor, praying that my lungs would last through the night. This year, I'm lucky. I have insurance. It started in January after a whole big fight with the insurance company. And you could,
Marianne, I hate to do this to you.
yeah, you got to cut me off. All right, so I'm gonna speed it up real quick.
I'm sorry.
No, remind me on time. But
Okay.
what I want to say is, in my time, I've now been in the hospital 3 times for the COVID pneumonia with the sepsis. When I was on that unit, the COVID only unit, 23 out of the 24 people were people of color. They were our Black and brown brothers and sisters, or they were people like me who are Latino but white presenting. There was one visibly Caucasian elderly woman on the unit, and she got visitors, and eventually she got moved to another unit, and the rest of us were there alone on that unit. And if I didn't have health insurance, I would not have gone to urgent care. If I hadn't gone to urgent care, they wouldn't have called the ambulance. And if they wouldn't have called the ambulance, I would have probably died of pneumonia alone on my couch. And there are too many people right now on Long Island and throughout New York State who are homeless, who are undocumented, who are uninsured, who have lost their health insurance because they've lost their jobs. And if we had the New York Health Act, every single person would be covered, and this pandemic would not have spiraled the way it has. And that is why we need the New York Health Act. We need to cover undocumented people. We need to cover non-working people. We need to cover the unemployed and the underemployed and the sick and the elderly and the disabled, because right now our shitty US capitalist profit-driven health insurance system is fueling the COVID pandemic. I'm done. Thank you.
Yep. Thank you, Mariana. Suzanne, we're going to go to you next. Just unmute yourself.
Okay. 1991, I was self-employed, working from home, couldn't have afforded health insurance with the money that I was making with my growing business. But I was married, and my husband had insurance that covered him and the family, and that was great. That same year, I was afflicted with a disability which required very expensive treatments on a regular basis and was going to require it for the rest of my life. My husband was 8 years older than I was and knew that men generally don't live as long as women, and was sure he was going to die before I did, and was very concerned about how I would cover my medical bills after he was gone. So he left his job and went to work for the Port Authority, where he got paid by New York State and had excellent benefits, including health care for himself and his wife for life. He hated the job. He stayed for 7 years so that I could have health insurance. Why should health insurance be tied to a job? It makes no sense. And I happen to be in a happy marriage, but what if I wasn't? There are people who are abused who stay in a relationship because they can't afford insurance and they want to keep their insurance. The system is wrong. It is, in my view, immoral. And I look forward to hearing the panelists give us details on what we should do about it.
And we are going to start that process right now. Our first presenter up is Dr. Martha Livingston. Dr. Livingston is a professor and chair of public health at SUNY at Old Westbury. She's also a national leader advocating for a single-payer healthcare system with the group Physicians for a National Health Program. Martha, you want to unmute yourself? Unmute yourself there.
Hey, everybody. So from those very personal stories, I generally like to start out with a personal anecdote, but I think we've had the personal anecdote for the moment. I may weave one or two more into my quick overview of what we're really talking about when we're advocating for what's sometimes called single payer, what more of us now call Medicare for all, and in the state of New York, we call the New York Health Act, which is a Medicare for all program, but on a state level. We'll hear more from Senator Rivera and from Katie Robbins about the New York Health Act specifically. So just as a broad overview, what does this kind of program mean? What's a single payer? I've been talking about this issue now for close to 30 years, and literally, single payer is a very wonky term. So I've actually had people in audiences say, but what if I'm married? So that's when you know that your language is bad, when it doesn't convey what you're talking about. Single payer simply means that the government pays the bill for our health care, period. It's the single payer. I was fortunate enough to spend some time in the UK when I was a teenager. And then when I was a graduate student, I spent several years in the province of Saskatchewan, Canada. And so I've lived with, broadly speaking, single payer, or let's just say national health care systems in other countries. So here's the quick version. Every other wealthy country in the world, and some not so wealthy countries, have figured out ways to make sure that everybody in their country has health care as a right, period, the end. They do it in many different kinds of ways. Germany is not the same as Taiwan. Australia is not the same as Spain. You get the picture. Every country is its own place. You know, we sometimes think of ourselves as American exceptionalism. It's us versus all those other countries. All those other countries are very different places with very different histories and cultures and philosophies, but they all have one thing in common that we have not yet grasped, and that is that healthcare is something that people need. Why? As Bernie once said, when somebody said, why should we be paying for somebody undocumented? Bernie said, because she's a human being, for crying out loud, which is really, that's it. That's the bottom line. So here we are alone among the nations in not providing this. And yet, we spend more than every other country on the planet on healthcare. Last year, approaching $3.5 trillion, that's with a trillion dollars on healthcare in this country. That is 18% of our gross domestic product, or in English, that means approaching $11,000 for every man, woman, and child in this country. That is by far more than any other country spends. So on the one hand, on the other hand, we're spending all of this money. On the other hand, we're not getting our money's worth. If we spent all of that money in the healthcare system on actually providing healthcare, we would have hands down the best healthcare in the world, bar none, case closed. But we don't. So where's the money going is your next obvious question. And there we talk about the army of profiteers standing between patients and caregivers and telling us what we can and can't have, what we can and can't do. And this is irrespective of whether we are well off and well insured. I'm a professor, I'm a state employee, I have good health care insurance, right? But no, I don't have the option to go to any provider I want. I don't have, and my caregiver does not have the option of simply saying, this is the treatment that you need, we agree on it, let's go ahead and do that. That's not how it works. Somebody somewhere gets to make that decision for us. Clinicians spend months of the year, rather than treating patients, on hassling with insurance companies to try to beg, borrow, and steal the care that we need. It's a ludicrous system. We are unique in the world in allowing for-profit industries, for-profit corporations, that's the healthcare insurance industry, that's the pharmaceutical industry, complete discretion over who gets what. And that costs a third of our healthcare dollars. So the conservative estimate is that were we to go to a single payer, improved Medicare for all system, we would immediately, every year, save, wait for it, $500 billion, $500 billion, just removing the profit out of the system, just removing the useless, time-consuming paperwork out of the system. And just that money alone is sufficient to cover everybody in this country for everything we could possibly need in terms of healthcare. So one other piece I want to touch on, which I know that Katie will also touch on, and Senator Rivera will also touch on, is we say Medicare for all, but we say improved Medicare for all, because we know that Medicare is terrific and it's very popular and it's a step in the right direction, but it is not truly comprehensive. It leaves out all those parts in our head, right? Our eyes, ears, and teeth, and it leaves out long-term care, and people have to buy supplemental insurance and they have to pay co-pays and so forth and so on. None of that, that's gone. If I go to the doctor in Canada, I walk in the door, they say, "Hi, Martha," and I get treated. Nobody asks me to show a card. Nobody asks me to fill out a piece of paper. I don't get, which I do in New York, a 9-page explanation of benefits form generated by my insurance company, complete waste of time, money, and paper, to say, oh, you went to the doctor. Look, we've generated this document to prove it. All of that complete extraneous, really useless paperwork is gone. That stuff adds no value to the system. In fact, what it does is actually not only take money out of the system, but take our caregivers' time to accomplish. We want that all gone. We simply want, and here's where we need some vision, folks, because we can't imagine just going to get health care when we need it, not having to worry about whether we can pay for the visit, pay for our medication, and going home and taking care of ourselves, taking care of our loved ones, and never having to worry again about all the trade-offs that Americans currently worry about. I think about the woman with the severe leg injury who fell on the tracks on the Boston subway. And when she's being rescued and pulled off the track and the ambulance is there to take her to the hospital, she says, no, 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 don't take me to the hospital. Just let me go home. I can't afford this. That is obscene, and we need to get rid of it. I want to close with this one story that I just heard yesterday or the day before of a recently unemployed 40-something-year-old steel worker from Kansas. This guy says the following thing. So he's lost his, okay, so here's the other piece. Sorry, I forgot to mention. Those of us who have health care, most of us have it through our employer. Well, here we are in the middle of the pandemic, and 25 million people have lost their jobs in the last month or so. And at least half of those had insurance and they no longer have insurance. So here's one living example of a guy named Chris Jump from Kansas who said, if it comes down to buying food for my kids or my insulin, I'm taking food for my kids. Diabetes almost killed me 2 years ago, but that kid's going to get a meal till dad's laying in the ground. That is an obscenity. This is a ludicrous situation that we're in. It's morally and economically untenable, and we need to move to a single payer, improved Medicare for all system nationally. And in the meantime, we need to accomplish this in New York with the New York Health Act. Thanks.
Okay, thank you, Dr. Morgan Livingston. And that leads us to our next presenter, who is the Honorable Senator from New York State, Gustavo Rivera, and there he is. State Senator Gustavo Rivera represents the 33rd Senate District in the Bronx. Since taking office, Senator Rivera has focused his efforts on addressing issues of health inequality.
Are you really going to read the whole bio?
I am. You sent it to me. It's
You should read the whole bio. We should not send out that. It's an old bio. You should. I mean, go ahead. It's your thing.
Honor your staff who sent it to me. You're good staff. I know Rachel very well here. In 2018, Senate Majority Leader Andrea Stewart Cousins appointed Senator Rivera as the chair of the Senate Health Committee. You should be proud of that. He is collaborating with colleagues, stakeholders, and constituents to improve health outcomes, increase access to health coverage, and ensure a financially viable healthcare system. Am I lying at any point here, Senator? Senator Rivera served as the ranking member of the Senate Health Committee for 6 years. In that role, he passed 3 smoking ban laws, very impressive, and has been a champion of harm reduction policies. He is currently the main sponsor of the New York Health Act and is co-author together with New York State Assemblyman Richard Gottfried. And just some closing thoughts here. In 2011, Senator Rivera launched the Bronx Can Health Initiative, CAN, can, capitalized. This health initiative shapes policies that will help tear down some of the institutional barriers that stand in the way of Bronxites having a healthier lifestyle.
Bronxites.
Your word, I don't think I put that word in there.
Bronxites.
Is that such a term? So we're honored to have you here, Senator. And I would like you to talk a little bit about that New York Health Act that you're supporting.
Absolutely. Well, thank you so much for the invitation. So again, my name is Gustavo Rivera, State Senator for the New York State District 30, the 33rd District, the fighting 33rd, which is up in the Boogie Down Bronx. Just in case you know, this is what we say, the hand signal we throw up our X's for the Bronx. This is Wakanda from Black Panther. This is the Bronx. That is not a coincidence. But in any event, so I'm just going to bottom line it because I definitely want to get to the Q&A because I think that that's going to be the most important part of this. Let's start with something very basic. Healthcare is a human right. You are a human being, therefore you're going to get sick, regardless of how old you are, what your gender is, your wealth, your immigration status. And so if you believe that healthcare is a human right, then we have to change the current system, which does not treat it like that. It treats it like a commodity. Now, if you do not agree with me that we should be responsible as a society for making certain that everyone has access to care, not access to insurance, and we'll get to that, but access to care. If you don't agree with me, if you think that there are some folks, some of my colleagues, most of them on the other side of the aisle, but even some of them secretly on my side of the aisle, who have a sense that if you can't afford something, then you shouldn't be able to get it. You know, it's like if you can't afford to get the Mercedes, then just get the Toyota and you'll be fine. Except that if you have cancer and a Mercedes will fix it, and you can only afford a Toyota, then what are we talking about? Healthcare is a human right, therefore we have to move away from a system that has a market mentality at its core as it relates to something that should be available to everyone just because they are a human. Now, what is it that, and one more point before I quickly go over the points of the New York Health Act and why it will save us money, and then I'll just pass it on. The idea, and this was said a little bit earlier, the idea that if you start with the idea that that healthcare is a human right, then follow it up with the idea that we should not perpetuate a system in which your job is what guarantees you or what gives you access to healthcare. And this situation that we find ourselves in right now is the clearest example of how insane that system is. Because there are literally millions of people around the country who did everything right, who went to work every day, who worked hard, who followed the rules, and all of a sudden, because something that is beyond their control, the economy goes to a standstill, and there's millions of people across the country that all of a sudden are jobless and now don't have health care because they're jobless. So a system in which we tie your healthcare access to having a job or not and having the right type of job, that we got to go away from that. So how does a single payer system, and we said it a little bit earlier, right now we have a multi-payer system. What that means is that whoever the provider is, a hospital, a doctor, whatever, gets paid from different sources. That is a multiple payer system. A single payer system means that providers, doctors, hospitals, clinics, etc., get paid from one place. This case, the state, as in a government entity. And what would be, how would you would say to yourself, because my opponents, the opponents obviously go immediately and say, well, wait a minute, that costs way too much money. You already heard the fact that the system that we have is already expensive. It is already the most expensive in the world, yet doesn't give us the best results. Why is that? Because there's a lot of, for two reasons. Number one, because there's a lot of money that is wasted and not actually spent on caring for people. And two, because as we said before, the market mentality is at the center of the current system. So the entities that decide whether you get care, insurance companies, the folks that decide whether you get care or not, are not there making decisions on whether you get care or not. They're making decisions as far as how much money they're going to keep. Because for every dollar that they don't give you for care, they get to keep it for themselves. So how does a single payer system save money? Well, first of all, any insurance product works by sharing risk. If we all, everybody on this call, if we all put a gallon of water a month into a big pool, right? And then some of us need 5 ounces every month, and some of us need three gallons every month, but because we're all putting it into the same pool, the risks pool stays in about the same place because we're all sharing the risk among all of us. Some of us are high-end users, some of us are low-end users, but because we all put into it, then it all balances out. And there's people that can afford to put 4 gallons a month or 10 gallons a month. Well, let's make sure that they put 10 gallons while you put 1. And the folks who can't afford to put any gallons, they can still drink from the same pool. So we all share the risk. And if you share the risk among the entire population of the state of New York, that's one way you save money. Number 2, administrative costs. The notion that for 15 to 18 cents out of every dollar currently in a private insurance system goes to administrative costs. That is salary CEOs, marketing, paying for all those people who you or your doctor are on the phone with saying like, no, it was the other test and they need it. This is medically necessary. No. Okay, so I need to send what paper? Okay, what paperwork? What form do I need to send? All the individuals that they pay for that do that, whose job it is to deny you care, how about we go from 15 to 18 cents out of every dollar to 3 to 6 cents out of every dollar? So if you spend that much less, you're saving money. Third, you negotiate for drugs with drug companies on behalf of the entire population of the state of New York. Now, we all know how this works. If you go to a store and you say, I want to buy 5 widgets, okay, each widget will cost you $5. But if I go into that same store and say, I want to buy 1 million widgets, I was like, wait a minute, we can give you a better price. So if you are the state of New York and New York Health negotiating with a drug company on behalf of 20 million people, the drug companies want our business. They will give us a better price. We'll save money there. Last, but certainly not least, and I should have started with this, but I wanted to end with it because it is important to just understand it. Making sure that everybody has primary care. That means that for those individuals who are uninsured, who currently there are many, when they get sick, because again, they're humans, what's going to happen to them? They're going to go and get taken care of. Where? The emergency room, which we all pay for, and which is the most expensive type of care. And obviously, because of everything that goes on in emergency rooms, even in normal times, it is not the highest quality care. Just for the sake of like just normal, right? It is an emergency room. People that go there need care immediately. It kind of limits the ability of amazing healthcare practitioners. In that environment, though, it is hard to provide high quality care. So if you provide everyone with primary care, it means that they don't have to wait for a month for that pain that was on the left side of their stomach. And they're just popping Tylenol and Advil to see if they can make it go away because they're not insured. And when they wake up and they can barely stand up because of the pain, that's when they go and they got to do something that costs a lot more money. So how about we provide primary care for everyone so they don't have to worry about where they're going to get their care? And if you provide primary care as well, you identify chronic conditions like asthma or diabetes, which are actually much better to maintain. Like you can maintain someone as opposed to treating them when they're just at their worst. So if you do all of those things, you share risk, cut administrative costs, negotiate for drugs on behalf of the entire state, provide primary care to everybody, you not only create a better condition for individuals and communities, but actually save us a whole lot of money. And so I look forward to all the questions that you have, but I will end with this. This situation that we find ourselves in right now is the clearest example of what was broken in the system. Many of the individuals that you heard from, the stories, and I'm sure that many of the people who are seeing this right now have stories of their own about how the current system has messed them up and has attacked their families. The cruelty of the system, I'm sure, is obvious in many of the stories that you could tell. So you knew how broken the system was. Many other folks ignored it. They were able to because they had a good job, because they had never seen it in their own lives. But now that we are beyond that, we're seeing very clearly how immediate this is as a need. And therefore, I suggest that while certainly a national program is the way to go, if we can't achieve that, and with this festering pile of orange feces in the White House, I'm not sure we can. So how about we do it right here in the state of New York? We must pursue it here. We have not only an opportunity, because now everybody sees the broken parts of it, but an obligation. So join us to see if we can get this done. I look forward to all of your questions. And more importantly, I look forward to celebrating with you when we freaking pass this thing. Thank you.
Thank you, Senator. A little clap for me on my end here. A big clap, actually. Mariana, you're up next. Just unmute yourself. You're muted right now.
All right, I was muted. Sorry. All right. Can everybody hear me? Can everybody see me?
Yes.
Okay, excellent. So it is my pleasure to introduce a comrade and a good personal friend, Katie Robbins. She's the director of the Campaign for New York Health, which is the statewide campaign advocating for universal guaranteed health care in New York. She was a national organizer with Healthcare Now from 2008 rather to 2011 during the healthcare debate leading to the passage of the Affordable Care Act. And there's a really awesome documentary where you see her and her comrades, you know, getting pulled out and getting arrested. And she is one of the realest organizers I know. She's a graduate from Columbia's Mailman School of Public Health. She lives with her amazing husband, Total Relationship Goals, and their adorable little daughter, who has, you know, she's a red diaper baby, just like my son, Max. She lives in New York City, and she's been doing such tremendous work. You know, I met her through, I think, probably our NYSNA work, the New York State Nurses Association, which has been really integral in working on the New York Health Act. And it gives me such great pleasure to introduce my friend and comrade, Katie.
Katie, you need to
Hi.
unmute. Okay.
I'm here. Thank you. Thank you, Mariana. I really appreciate those kind words. And it's a pleasure to be with you all today virtually for this discussion. I am feeling really moved right now, connecting with the Long Island activists at this time. And I just want to start out my remarks with remembering a really incredible activist from Long Island that many of us worked with, Candace Hildebrandt. Candace was a leader with LIA. She was forceful in her advocacy for the New York Health Act and Medicare for All because she herself lived with many chronic health conditions and could speak firsthand to having insurance and not being able to get the care that she needed. And sadly, about a little over a year ago, Candace passed away. And there's a few people, including Candace, who have been really close to us in our organizing, who I feel like would still be here at this time if we had a universal healthcare system that had eliminated financial barriers to care. So I'm keeping Candace in my heart today. I feel her spirit with us in this virtual town hall. And I am grateful for the work that continues with Long Island activists and working with you all. I'm actually going to attempt to see if I can share my screen so that I can work through a few slides here. Let's see if this will work. Hang on just a moment. So I'm presenting on my end, but I don't think you can see it. Hang on one second. Okay, share the desktop. Okay. Hey, can you see my slide there?
Yes.
Great. So I was asked to answer this question today. How will the New York Health Act change our lives? And I think this is a critical question to ask us when we're doing the organizing work, right? How is this issue of universal guaranteed healthcare, of passing the New York Health Act, of winning improved Medicare for all, how is this personal to us? And when I started doing this work, I would talk about my personal story and ask other people to share their stories. And sometimes it would come up that people would say, you know, I don't really have a healthcare story. Maybe thinking like, I don't have chronic health conditions, or you know, I haven't had to, you know, go to the doctor and struggle with accessing care, or something really dramatic like a big diagnosis like cancer or something like that. But really this issue weaves its way into so many different aspects of our lives that it's sometimes hard to even like step back and recognize how the decisions we make are affected by the way our healthcare system is designed. So the questions we ask through surveys and organizing tools where we go out and have conversations with people that I want the people listening in right now to ask themselves is, how would your life change if you had guaranteed healthcare? Have you stayed in a job or a relationship because you needed the health insurance? Have you struggled to access long-term care services for your family members or yourself? Have you ever had to choose between paying for healthcare and other necessities, such as rent, food, or transportation? How about hospitals and clinics? Have any closed in your area? We've seen dozens of hospitals close across the state in the last 20 years. How are you a business owner or nonprofit owner that struggles to provide health insurance for you and your employees because of cost? Those are all critical questions for understanding how this affects us personally. And I'll share here, this is actually a wedding announcement for me and my husband. We were married about 10 years ago. I really do like this guy, but also we sped up the wedding because I needed to get him on my health insurance. That's our very romantic story, right? Now I know it worked out okay for us personally, but I also worked in domestic violence shelters throughout rural Ohio years ago, and worked directly with families who really were not in a good place with their marriage and returned to unsafe homes, needing to stay on the health insurance of their spouse. So we tie health insurance, as we've said, to our jobs, to marriage, to our income level, to our immigration status, to all of these things that actually have nothing to do with being human and needing healthcare, which everybody will need at one point in their lives. So we have tried to do work at the Campaign for New York Health to really center our organizing around real people talking about how this affects our lives in real ways. Like I said, it doesn't always have to be a big dramatic story to help to break down the stigma around challenges in affording healthcare or accessing care. One simple story that I tell a lot that people relate to is, my daughter, who's now 5, had a terrible habit of putting small objects up her nose a few years ago. And we would have to go to the urgent care center in the neighborhood. And each time I went to have, the popcorn kernel or bead removed, it cost my family $250. And so being faced with that $250 bill was, the question of how will we afford our groceries for the next couple of weeks, right? That's a question that people are asking all the time because healthcare costs are so out of control. And we encourage people to think of creative ways to get their stories out there. So what you see on the screen now are 3 very powerful short written testimonials from amazing activists in the Campaign for New York Health in New York State. You have Scott Denoyer, who's holding up a picture of his son, Danny, who sadly lost his life when he was not able to afford a $20 insurance payment and lost access to his life-sustaining mental health medication he was on. In the middle, we have Sarah, who's an amazing activist in Buffalo, talking about her challenges with bipolar disorder and struggling to find providers in her area who will care for her. And on the right, you have this amazing person with the Northwest Bronx Community Clergy Coalition talking about the 6 months it took for his grandfather to get insured, and his grandfather died waiting for care. So these are simple ways that we can get the message out about our personal stake in this fight. And I encourage people who are listening in, all you need is a piece of paper and a pen or marker to write out your story and post it on social media and tag us at NYH Campaign or #PassNYHealth. And you can be part of this amazing statewide effort to tell our stories about how desperately we need the New York Health Act. And, we've been out talking about this issue long before the current pandemic that we're faced with, which of course highlights how desperately we need a fully insured society to fight back against the coronavirus and be ready the next time something like this happens. But last year we put out this report from Coverage to Care, a People's Report on Healthcare in New York State. We talked to thousands of New Yorkers, and before the pandemic, we found that 50% of the folks we spoke to skipped or delayed at least one type of care because of cost. And these were people who had private insurance. In addition, 1 out of 3 of the people who said that they delayed or skipped care developed more serious conditions because of not getting the care that they needed. And a really high number of folks reported being uninsured at some point in their lives. 73% said at some point in their lives they had been uninsured. More than half had been uninsured for at least a year. And many reported having been uninsured for 5 years or more. So we knew that the crisis in our healthcare system existed long before COVID-19, but here we are in the middle of this pandemic where our lives have been upended. Over 1 million New Yorkers have lost insurance. Many of them have lost their health insurance with their jobs. And it has never been more clear that the people who are facing the brunt of this crisis before and after COVID-19 are the people who are considered our essential workers, often the lowest paid, and very often the people who are coming from Black and Brown communities in New York. The senator here, Senator Rivera, representing the Bronx, is the hardest hit borough, the hardest hit county in all of New York State. The deaths in the Bronx are twice what they are in other boroughs. So we are seeing in real time how awful this crisis is for the people who've always been impacted the most by the failures of our market-based healthcare system. And so it is more important than ever, if we're going to center any justice in this response, in our ability to recover from this pandemic, that we must pass the New York Health Act to guarantee healthcare to every single resident and worker in New York State. It is the right thing to do. It's the moral thing to do. It's economically beneficial to the state. It will make our healthcare system work better, cost less money, and it will build up the health of the people who are most impacted by the failures of the current system. So we have some resources making the case for the New York Health Act in the era of the coronavirus and social distancing, and you'll see where you can access that information here. And we just want to end on a positive note that the people are so ready for universal guaranteed health care. You know, poll after poll is showing people support single payer. 94% of people support healthcare as a human right, and that it is time to see the political courage to get us across the finish line. And again, encouraging people to speak out about the stories, their own experiences with healthcare. We know that when we tell our stories, we connect with other people's values. We motivate people to join us. And basically, we are creating community through this work by creating common purpose when there's so much uncertainty. So I'm going to make an appeal to everybody to participate in our story selfie for social media. I'll be looking out to see if anybody's jumping in on this today. You know, you can take action right now during this virtual town hall. And then I think I'll wait till the end to go through the rest of the action items that we have according to the agenda laid out today. But with that, I'll just say thank you so much for the opportunity to be here and talk about how important it is to center the New York Health Act and the recovery for the pandemic, and to build with all of you the movement we need to really get this done. Thank you.
Thank you, Katie.
See, stop share.
I just want to make an announcement here. I know there are many people watching this presentation on Facebook Live. We're not going to be hearing from you through that medium, but we will be listening in on the chat. We're watching the chat, reading the chat. So if you have any questions you want to have asked, put them there now, if you haven't already done so. For those that are watching this program through Zoom, you too can post your questions through chat. We're going to have actually one of our members read your questions on air in a little bit. Our next presenter is Dr. Cheryl Cashin. Dr. Cashin is the managing director of an organization called Results for Development in the global health practice. In that role, she co-leads a portfolio of more than 20 projects and initiatives in global health systems, and she serves on the board, on the executive team of Results for Development. Also, Cheryl is very familiar with implementing single-payer healthcare systems around the world. Through her efforts over the past decade or so, close to a dozen, if not more, you can correct me on this, Cheryl, you've actually helped implement in many third world countries. I know more recently she's been involved with the healthcare system in Indonesia, which she helped start up back in 2014. She literally just came back from Indonesia a couple weeks ago. So maybe she could talk a little bit about that. But Dr. Cashin has been asked to be part of this presentation to talk about how single-payer agencies can be strategic in ways that private insurers cannot. And you are muted right now, Cheryl. Dr. Welcome.
Thanks so much, Robert. Good afternoon, everyone. It's just such a privilege to be here on this panel with so many of my healthcare heroes. It's just amazing for me, having been working internationally, globally for actually 25 years, Robert, not 10, that I have a chance now to possibly help to make a profound difference at home. And this is the first time, and this is thanks to all of you. So I really want to acknowledge that. Listening to all of you share just the terrible stories that we know are just everyday people are experiencing with our healthcare system, but also hearing that we have a solution. out there on the table. There's a solution. Martha and Gustavo and Katie, if there's a solution there that makes sense, it would save money and it would solve a lot of these problems. And so to me, it seems like a no-brainer. So why haven't we been able to get here? And I think one of the problems is that people are afraid of the devil they don't know. And this idea that actually we could make the system worse is on people's mind. And the myth that I would like to talk about today is the myth that a government agency would do worse than the private insurers at playing the role of financing in our health system. And this really comes from my experience of working with a lot of single-payer government agencies in a lot of countries that have a lot less to work with than we do. And they're able to bring value to the system. So I want to share a little bit about that experience and how I think we can make the case that is not a scary leap to go from the private for-profit model to a single-payer government agency to finance our health system. So when I was preparing for today, I kind of got a little bit nostalgic, and I went back to my first experience working for a single-payer agency, helping in Kazakhstan. This is the former Soviet Republic of Kazakhstan. This was in 1997 when they just passed their national health insurance bill. And I was able to sit in the office of this new agency when they opened their doors. And this is one of the states in Kazakhstan, Zhezkazgan at the center. And we helped them enroll everyone in a primary care provider of their choice. So this idea that we'll be losing choice if we move to a single payer system is another myth that we need to refute. So people came out for the first time in the post-Soviet period and chose their family doctor. And then we helped to design a way to pay these doctors a lump sum in advance every month to pay for all the care, all the primary care services that people were entitled to. And this lump sum payment in advance was very important because Zhezkazgan had a very low population density. And if the primary care doctors only got paid when they saw patients, they would have gone bankrupt. And we're seeing a very similar situation right now in our country for a different reason. Because of the COVID-19 pandemic, hospitals are having to cancel elective services, nobody's going to the doctor, and if you don't deliver services, you don't get paid. And I'll talk more about that in a minute. But at this time in Zhezkazgan in Kazakhstan, it really, for me, opened up this idea of what the power is of single-payer healthcare. And since that time, I've worked with a number of different agencies in different countries, as Robert mentioned, most recently in Indonesia with their single-payer system. And so what I wanted to share today, just 3 areas where I think these agencies bring value that our private insurance layer does not bring. And those 3 areas first are a system-wide view that single-payer agencies can look across the whole system, set priorities for the whole system, and then plan and manage resources to meet the objectives and priorities. The second, I think, huge benefit that these agencies bring, and a number of the presenters touched on this, is strategically paying healthcare providers, being very strategic in how and how much we pay to help achieve our objectives. And then finally, the third benefit that I have seen with my own eyes is that these agencies are accountable to people and voters, not shareholders. And that makes a huge difference in their behavior. So I want to talk about the first one, and I think this first one is really very pertinent, having a system-wide view and the ability to plan and manage resources. And I found this quote from a Canadian expert that really struck me as being just capturing this, that in this time of crisis of the coronavirus COVID-19 pandemic, that the healthcare system can be a public strategic asset rather than a business run for profit, and to actually be able to use the resources that we have optimally. And that is something that we clearly have not been able to do in our for-profit system. And just last week, my team and I were able to invite a group of experts from Korea's single-payer agency to talk to our network of countries that we work with who are interested in hearing the role of the single-payer agency in Korea's COVID-19 response, which is recognized as one of the best in the world so far. As most of you know, I think South Korea confirmed their first case of COVID-19 on the same day we did, the United States, on January 20th. They have fewer than 11,000 cases, fewer than 250 deaths. In Suffolk County, where I live, this weekend, we passed 1,000 deaths. So what have they done? They have done many things. Some of those things we might not find easy to do in the United States, but their single payer agency was able to right away make sure right away all services related to COVID-19 were in the benefit package. And that meant that everyone had access to all those services because everybody's covered. They were able to put the services on the price list so that all the providers knew they would be paid, and they knew how much they would be paid for any services related to COVID-19. In fact, they raised the prices, the single payer agency raised the prices of these services to 60 to 100% above normal to compensate the hospitals for the other services that they weren't delivering. These are private hospitals, but working together with the single payer agency to make sure this response was coordinated. And the third thing that they did, they were able to get the hospitals together, do an inventory of the staff, the beds, the equipment, and redeploy as needed. These hospitals knew that it was okay to do that. They weren't going to lose money. They weren't going to have to go out on the open market to fill gaps, that they could work together in this cooperative system. Now compare that to what's happening in our country today, that hospitals are having to shut down elective services. There are very dire predictions about hospital closures. Our whole ambulatory care sector, we don't know how they're going to survive this financially. What is our health system going to look like when we get to the other end of this crisis? A single payer agency would be able to step in and stop that from happening. That brings me to the next issue where there is a lot of opportunity to be strategic when you are the one payer and you have the purchasing power that Gustavo talked about. And that is in the pricing and the payment. And there is, I think, no more non-transparent part of our system than prices. I think we've all opened our explanation of benefits forms or looked at surprise bills, and the prices make no sense. What the hospitals charge, what the insurers pay, there is such a lack of transparency. And at least the Medicare system has a formula for how they calculate payment rates. There's some negotiation, there's some basis in cost. It's more transparent. But when the private insurers are actually dominating that market, that really reduces the power that Medicare has in the system. And I just wanted to share a couple of examples of what this does to distort our system. Here's a recent study by the Kaiser Family Foundation that showed that on average, private insurers pay prices that are twice as high as Medicare. And we're thinking, well, these private insurers are trying to make a profit. Wouldn't they be squeezing? And yes, they do squeeze some providers, but actually, it's very easy to pass these higher prices on to us in terms of higher premiums, deductibles, and co-payments. So the insurance companies use other, much easier for them, ways to squeeze and make profits, denying care, shifting costs, and restricting access to providers. These are things that we're all very familiar with. So these higher prices really make us an outlier in the world. And this is another study that looks at prices for different health services across 8 countries. And that column of red dots on the right are US prices as the benchmark. And all the other dots are the prices in other countries for the same services as a percentage of prices in the US. And if you look across, most of them are 50% or less of our prices. And this is even in Switzerland and the Netherlands, which have the highest cost health systems in Europe, and actually very high prices for other non-health related things. I don't know if you've been there, but to get a cup of coffee or a taxi ride in Geneva is way more expensive than in the United States. But their healthcare prices are half the level of ours. And I don't think anyone is saying that we want to squeeze our hospitals, squeeze the providers and not pay enough, but it's paying strategically and in a transparent way. And I like the example of the UK, maternity services in the UK. If you look at what they pay for a normal delivery, it's almost as much as we pay in the United States. That's a high priority service, and they pay very well for that service. But C-sections, which have been really rising recently to levels beyond what would be indicated based on their clinical guidelines, they pay lower, about 50% of the US price. So that's a strategic use of pricing to push service delivery where we think we get more value for money. As Gustavo said, putting more towards primary care will actually save us money in the other parts of the system. So a lot of these single payer systems pay disproportionately higher prices for primary care services than for tertiary care services that bring less value. So just a last point on the benefits that these single payer agencies, the agencies themselves can bring to the system, is related to accountability. I don't want to say this picture is overly rosy, that it's perfect. If these agencies were perfect, I probably wouldn't have a job. There are risks. There are risks putting all of your money through one payer, through a government agency. There are risks that these agencies won't make the best use of these levers that I've been talking about. They won't be effective. There are risks that the revenue that is supposed to come to them through the tax system is going to get politicized. All of these risks are there. The difference is that they are explicit, that we know what they are. And in fact, the New York Health Act has written in a number of provisions to help guard against some of these risks. And it's more transparent. We will be able to see what's happening, and we as voters will have a recourse. We don't have recourse against private health insurance. We are just passive victims of that system in many cases. We don't even know what their behavior is unless Kaiser Family Foundation publishes a study, or a news outlet releases another article that enrages all of us again. If we were to have a system that were accountable to voters, they would have the mechanism to meet the objectives that we set for our system. They would have the mandate, and they would be accountable to us to follow through. And none of that is true in our private system today. So I'd like to stop there. Thank you.
All right. Thank you, Dr. Cashin. Mariana? And you're right now.
Sorry, okay, I was unmuting myself, and then I need to get back to their screen because I've been sharing this like crazy. I now have the pleasure of introducing Susan. Susan is, again, a personal friend that I've had the pleasure of organizing for the New York Health Act for through the Poor People's Campaign. Susan is currently the co-chair of the Long Island Regional Committee of the New York State Poor People's Campaign, which is, you know, the national call for moral revival based on the work of Martin Luther King. We are picking up where he left off. She's also a member of the New York State Coordinating Committee and CARE team, and she's here to speak about healthcare from the perspective of the Poor People's Campaign, and is just such an incredible woman, and I'm so thrilled that she's here with us today.
Thank you, Mariana, and hello to all of you. We in the Poor People's Campaign believe that health care for all is a human right. The Poor People's Campaign has been active in the fight for health care for all in New York State and for Medicare for all nationwide. Passing the New York Health Act is a first step in guaranteeing better health in our state and our country, but it is only the first step. So once this bill is passed, and it will pass if we all take the steps that Katie will present to us at the end of this town hall, I hope that you will continue to fight for equity in healthcare. First, to make sure the bill is implemented. We know just last year a wonderful Progressive Bail Reform Act that was passed and was then set back in the next session because it wasn't funded, and because in the funding bill, they cut back on what it would cover, which is directly related to health now with COVID-19. Jails are very unhealthy places. They're very crowded and unsanitary. The life expectancy in prison is much lower than in the general population. They consider people in prison to be elderly when they're 50. So now with COVID-19, this is a major problem, and because of the setback in the bail reform, there are going to be more people put into prison instead of fewer. We don't want something like this to happen with the Health Care Act. When it gets passed, we want to make sure that it's passed without any of its provisions being taken out, that they don't find some way to screw it up. So we'll all have a party and congratulate ourselves and be very happy that it passes, but then we have to get back to work and keep a close eye on it. So there are other issues related to the disparate health in our country besides lack of insurance or lack of affordable health care. Poor people and people of color have lower life expectancies and more chronic illnesses than the rest of us, and not just because they can't afford good health care. What are some of the other reasons? A lack of safe and affordable housing. Can you imagine worrying about where you're going to sleep tonight? The physical conditions of not having a safe, affordable place to live is one aspect. Another is the stress. There are countries and places, and I gotta get my dog off my lap. Go. He's making this hard for me. He wants to be part of it. British Columbia, Cuba, Finland, and I understand China, guarantee housing for everyone. Everyone is given a place to live, whether they can afford it or not. And you know what? The costs of their social programs are lower than ours, because once people don't have to worry about where they're going to sleep, their health improves, their ability to spend time getting a job, the stress that was causing them to become addicts is much easier to handle. And overall, they find that health improves. So we need not just single payer healthcare, we need housing for all as a guarantee. There are 6 times as many empty houses as there are homeless people. 6 times as many empty houses, and people are not being allowed to move into them. People are crowded, low-income people are crowded into unsafe housing where they're subjected to lead paint, unclean water, rodent infestations, and overcrowding, which of course is now a big problem with COVID-19, always a problem with diseases that are infectious. Another cause of health problems being exacerbated in poor communities and communities of color is pollution. The industries, the polluting industries, don't build their facilities in my neighborhood. They build them in and near the poor people, or the communities that poor people can afford to live in are the ones that are next to where these places are. And the incidence of asthma, COPD, and other respiratory illnesses is caused directly by the air that they're forced to breathe. The unsafe water that they're forced to drink is poisonous. And this has become an issue around the country. I do not understand why water is so expensive, but it is. And there are people who don't have water. And with COVID-19, we're told to wash our hands regularly. There are people out there who have no water to wash their hands. Or at the very least, they don't have clean hot water and soap. And this goes back to the prisons too. They're making hand sanitizer in the prisons in New York State, but they're not allowed to use it and have it in their rooms because it contains alcohol. It's against the rules for them to use the sanitizer that they're making. So, because we are devastating the planet we live on and it's affecting the health of all of us, I hope that when you're looking for a new issue to work on after we've passed healthcare for all and Medicare for all, that you'll think about joining the fight for the Green New Deal, which will improve the health of all of us. Militarism and criminal injustice. Hopelessness and stress. When I say militarism, I'm thinking of 2 different things, and one is financial. 65 cents out of every discretionary dollar in the federal budget goes to the military. And it doesn't go to the soldiers and to the veterans. I volunteer at a food bank, and there are a lot of veterans coming to food banks to get food. And then there's the militarism that is taking over in our country with increased policing, increased word escapes me, but okay, increased policing, putting people in jail, and especially, again, people of color. So even when the New York Health Act is passed, there's still going to be discrepancies in care and in health, and there are many other things that need to be addressed before we will all be equally healthy. People of color are not genetically predisposed to get sick more than we are. It is a fact of structural racism in our country that puts them in positions where they have poorer health and lower life expectancies. All of these things are related, and they are all caused by the capitalist power structure in our country that values profits before people. What we need, as the Reverend Martin Luther King Jr. said more than 50 years ago, is a revolution in values. We must fight to promote a system that values people before profits. The Poor People's Campaign, a national call for moral revival, is working toward making this the country we always said we were, or aimed to be, but never were, a true democracy, guaranteeing life, liberty, and the pursuit of happiness for all, because everybody has the right to live, everybody has the right to thrive, and everybody has the right to quality health care. Thank you.
Thank you, Susan. All right, we have approximately a half hour left in this presentation, and what we're going to move on to next is questions and answers. The first set of questions are going to come from Mariana and I. We're going to ask about 6 questions total, and then we're going to open it up to the chat questions. One of our Long Island activist members, Amy Benjamin, is on hand to address questions that have come in through Zoom. And we have all kinds of people monitoring the Facebook chat, and they've already been sending us all kinds of good questions. So I'm going to start off with a kind of a general question. Anybody can answer any of these questions, and I think you addressed it, but I'm not 100% sure. Question is, could I keep my doctor under single payer? Will I be able to keep the doctor? What's the doctor situation?
Yes. And the reason for that is that right now, even if you're insured, there are networks that are predetermined by your insurance company, meaning who you can actually go to. Our goal with the New York Health Act is to create one network, the entire state of New York. And since every person who's a New Yorker will be eligible for it and will have it, then your doctor will accept it. And by the way, just a couple of quick things here. There's a reference that was done to one of the questions that was asked about whether rich people are going to have a different system. Nope, they're going to have the same one. The goal here is to create one standard for everyone. And furthermore, the bill actually includes language that does not exist currently in law that says that the reimbursement rates that should be set have to correspond to what the care actually costs to provide. Currently, if you go to a doctor, many doctors don't take Medicaid, and the reason they don't take Medicaid is because Medicaid pays a very low rate. Medicare pays a little bit higher, and private insurers, like commercial payers, pay all the way up here. How about if we just equalize that so that we say that the cost of the care is going to what needs to be considered when setting the standard for how doctors are going to be paid. So all doctors will be paid much better than getting paid with Medicaid. Now, some of the larger hospitals might not be happy at this because they like sitting on billions of dollars of endowments and then get a lot of commercial payers. But I'm less worried about the NYUs and the Mount Sinai's of the world. I'm more worried about the public hospitals and the safety net hospitals all across the state. So there's answered a couple of questions in one question.
Okay, thank you. Mariana, do you have a question?
Well, we have 2 in the chat. Mary Raymond wants to know, for now, how do uninsured people get access to healthcare for COVID-19 symptoms? I'm going to jump on that for a second. I have a friend who is undocumented. He has an active asylum claim. He was working full time, but as an undocumented person, he was not eligible for employee-sponsored health care and was ineligible, as an undocumented person for Medicaid. He got sick and extremely sick. And when you are undocumented, your only alternative is A, pay out of pocket, which, most of us cannot afford to do, or B, you rely on your emergency room. He went to the emergency room. He had the symptoms. He was diagnosed COVID positive. And when he returned home to Brentwood to the rented room, his landlady evicted him. He was COVID positive and homeless. He was living in his car. It is illegal for landlords to evict their tenants right now. However, that doesn't mean it's not happening. And unfortunately, when you are an undocumented person, when you don't have legal immigration status, you are invisible and you have no rights. So my friend was living in his car and his fever escalated. And he had what food and water he had with him in his car. And eventually he ran out of food and water in his car. And he knew that he was COVID positive. So he was unwilling to go to any stores to buy food and water because he did not want to risk exposing other people to his illness. And so what we had to do was start a GoFundMe so that we could rent an Airbnb so that we could get him a safe place to stay to recover. And myself and other people from the Democratic Socialists of America, both Nassau and Suffolk County, and other comrades went to the pharmacies and paid for his prescriptions out of pocket ourselves and delivered them to his house. The problem is there are not enough GoFundMes and there are not enough DSA volunteers that we're all going to be able to pay for each other's out-of-pocket medication. And we're not all going to be able to go to each other's, pharmacies, and not everybody gets a GoFundMe. That's what's wrong with the system right now. We should not have to rely on GoFundMes for basic human rights like shelter and medication and food and water. And that is what this country is. And to echo what Susan said, the problem is capitalism. And the COVID virus has exposed the failings of capitalism. It's a failed experiment. If human beings cannot have clean water, cannot have food, cannot get medical attention in arguably one of the wealthiest countries in the world, then clearly the capitalist experiment has failed and we need to move on. And so currently, once, the GoFundMe can only raise so much money and we can only pay so long for an Airbnb, my friend went and stayed somewhere else. And his car, the car that he had been living in, got towed because it was illegally parked. And if you know anything about poverty in America, you know that everybody, who is working class and struggling and going paycheck to paycheck is just one paycheck away or one unexpected diagnosis or one, unexpected expense away from abject poverty and homelessness. And so when his car got towed, he no longer had transportation. And if he would have gotten kicked out of the next place he was staying, he would have no longer had shelter. So folks from Suffolk DSA and Nassau DSA have worked together. We have gotten him a room to stay in until schools reopen. But undocumented people and uninsured people right now are fucked. And that's
if I may for a second, only because I agree with everything you're saying, but one thing that I will say for the record is that we were able to, and when I say we, my colleague in the Assembly, Dick Gottfried, who's also the sponsor of this bill, together we were able to push the governor to actually expand Medicaid for undocumented people so that during the crisis, they will be covered both for tests and treatment.
Okay, so here's the problem. I consider myself an educated and well-connected and plugged-in person, and I'm fortunate enough to have, although it's a really shitty school-issued computer, I have a computer and I have money to pay internet access. But what about people who don't have internet access, who have language barriers? Because I didn't even know about what you just told me. So how are we getting that information to our brothers and sisters who are undocumented, who don't have internet access, and who are non-English speaking? Because when I was in the hospital myself for COVID, that's what I was surrounded by. I was surrounded by non-English speaking people and people of color.
Yeah. Well, you're pointing out something that's absolutely a challenge, and I will only be brief, obviously, because you want to go to the next question. But it is an absolute challenge. Obviously, I was going to say in things like this, conversations like this, people can get information. You said about people that are not, that do not have access to the internet. I understand that that is a problem. We have been working along, my office has been working along with a lot of community-based organizations that connect directly with people on the ground up here in the Bronx. I know that my colleagues, many of my colleagues have been doing that in other places in the state, certainly in Queens, I know for a fact, in Brooklyn as well. So it is a challenge. I'm not saying that I have a solution, but I can tell you, I just wanted to make sure that that information was out there, that we were able to achieve that. It is one of the few things that we've been able to push the governor to do the right thing. In this case, he did. So during the crisis, again, people who are undocumented will be covered for both the test and the treatment. So I just want to put that out there.
Okay, so then we need to do a better job of amplifying that message in
Yes, ma'am.
non-traditional communities. What we're doing with DSA is we are printing information.
Ourselves in English and Spanish, and we are posting it in the bus stops throughout Long Island. And I urge our Long Island elected officials, hopefully, hello, Jim Gorin, hello, Todd Kaminsky, hello, John Brooks. I hope you are listening, because you all are not doing your job. I don't care if they are registered voters or not. They are your constituents. They are human beings, and you need to put out information in Spanish and what other languages need to be put out in your community. And you need to actually put out some paper, because not everybody has the privilege and the luxury of internet. Sorry.
All right. Does anybody else want to respond to Mariana's questions and comments? I'm going to go with another question. So one of the concerns out there has to deal with unions. Specifically, I'll just say I'm in a union. And while I do support the New York Health Act, I'll just put it out there, some of my colleagues don't. Okay, so let's be real here with the people in unions who say that they think they'll lose out or something if they switch to a single payer system. How can I convince them they won't be losing anything?
So I will be very brief, and then I'll pass it to Cheryl, because she actually started with something when she said that this is about a problem about the devil that you know, as opposed to the devil that you don't know. It starts with the fact that it is true, and it is a legitimate concern. I call it the bird in the hand problem. You have something, particularly folks like that public sector unions who have negotiated for years for the current benefits. I understand that they have a concern about whether we would offer something that is going to give them something that they do not have right now, right? They're going to like, but I have this. Are you serious that what's in there, what's behind that bush is going to be better than this bird that I have in the hand? So that is a concern. It is a legitimate thing that we're dealing with. The one thing I start with, there's a couple of things that I start with. Number one, to say to them, this bill includes long-term care, which is something that regardless of how Cadillac your plan is, it does not include. So that means, referring to to the analogy I made earlier about the big pool, right? You put a gallon in each day, you might only need 5 ounces today, but 10 years from now, 15 years from now, you might need gallons of it because you need long-term care, or your parents or other elderly family members need long-term care. If we have the New York Health Act, when we have the New York Health Act, it will be covered. And second, so it has long-term care. And second, even the absolute best plan has a limited network. So if you, and those networks can and do change without any involvement from you as an individual. So you can have, or your formulary, the list of drugs that is approved to be covered under your plan, those formularies can change. And sometimes without your involvement, most times without your involvement. So it is a legitimate concern that we're dealing with, and we're trying. I'm working along with many activists within the unions who are, because the union leadership is opposed to it in some ways, right? DC 37 in particular, and we are working with them to address their concerns. And I will hope that the situations like the ones that we're living in now demonstrate that we are only as protected as the weakest among us. So we want to make sure that we actually change that for everybody. But I'd like, maybe Cheryl can actually chime in here, because she actually started by saying the devil that you know and the devil that you don't know. So maybe she has something else to add.
Thanks, Gustavo. And yes, I think this is, it's definitely one of those cases. And if anything, if there could be anything good coming out of this COVID crisis, I think it takes everyone's illusions away that what you have now, you're going to always have. And so the insecurity that has been introduced in this moment, I think makes us all rethink what is being promised that you have forever. And we had at one of our groups, a teacher was telling us that she had her healthcare covered through her union, but they're now forcing them into Medicare Advantage programs. So that choice is not there. It's not the same as that protection that she thought that she had. So all I can say is that the countries where I have worked, where Medicare for All type programs have been put into law, they have become impossible to reverse. People want them, they will fight for them. And in all of the countries I work, both political parties now, or all of the parties, whatever the case may be, are supporting them. No one ever talks about removing them. So it's definitely something that once it's there, people find that there's very little opposition in general. Whether or not to have it, it's the how people still debate some of the details.
Dr.
Hi,
Keshe,
this is Martha Livingston. Can I chime in on this? So I'm a union member and activist, actually president of my campus chapter of my union, which is a constituent member of the AFT and New York State United Teachers. I think that the senator put it really well about the bird in the hand. My sense is that most of our union members are not terribly worried about this. Who is worried about this more is some of the union leadership. And we need to persuade them that with the New York Health Act, what happens is we take healthcare off the bargaining table and we're able to negotiate for more wages in our pockets and for, yes, exactly, Gustavo. This is the point. The point is leadership feel as though part of what they've accomplished, and it's a real accomplishment over the decades with our employment-based system, is that unions have in fact been the conduit through which American workers have gotten decent health care insurance. The fact of the matter is, by the way, I've got a slogan that is really an old Borscht Belt slogan: take my health insurance, please. Because even as a well-paid, supposedly well-insured union member, I've confronted bizarre obstacles to getting even the most routine care. I want to, as long as I've got the mic, give a shout out to Leslie Bennett from the UK, who has written into the chat and said nobody in the UK would stand for the system that we're dealing with for 1 second. For less than half of what we spend, they've got a national health service that they've had since 1948. And whatever inadequacies anybody may have heard, frankly, it's mostly BS. I want to address one other quick question on the chat. People talked about wait times in countries where they have healthcare. This is by and large either a myth or a lie. That is to say, the whole point of insurance companies and of the right wing is to terrify us. No, 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 you don't want those other systems because, oh my God, you know, pregnant women wait 10 months for maternity care. Of course, that's foolishness. And what we see is that with a rational system, what you do is everybody who needs care gets care, period, the end. If there are any areas that are not emergent, if you can wait for care, maybe you're going to wait. But you know what? You're going to wait for that care here. A, you're going to wait forever if you don't have insurance. But B, I've actually tried this out myself by calling doctors when I've been referred to specialists. So I call up and I say, you know, my doctor says I should see Dr. So-and-so. When can I come in? So the first thing they say is, what kind of insurance do you have? But even after I pass that milestone, they'll say, oh, let's see, it's April 26th. You can come in on July 17th. And I say, but wait, I have a problem now. doesn't matter. We have this myth that you can just walk into a doctor's office anytime if you've got bags full of cash. That's not true. And it's certainly not true in a rationally distributed healthcare system. There will be far fewer wait times. There will be no rationing of care. We have to get over those myths and lies and move along. I can assure you, not just my friend Leslie from the UK, but all of my Canadian friends would be on this call shouting at the screen and saying, what is wrong with folks? You really need to have the vision that we ought to be able to have health care as a right. And as my friend Michael Leidy says, that what we really lack and we really need about this is peace of mind.
Quick thing, if I may add, I'm going to write, there's something that I just wrote, a name that I just wrote on the chat here, Wendell Potter. All of you should actually go and seek this person out, particularly on Twitter. Wendell, Mr. Potter, I've had the pleasure of actually speaking to him in person. A brilliant dude who used to be a health company executive, an insurance company executive. So he was one of the dudes who was in the room early on when, all the way back when Hillary Clinton was fighting for this stuff, right? When she was first lady. And he was one of the people who was responsible for crafting messages for the insurance lobby. And ultimately he got a case of, I don't know, like he discovered his soul and he decided, I can't do this anymore. And so he left the industry. And every time that a lot of the things that come up even today, he consistently pushes back on. It's like, I heard that because I'm the one who wrote it, and let me tell you what they actually mean. So if you want to learn from someone who was personally involved in crafting some of the messaging to make us scared of the idea of a system that's not the one that we have now, Wendell Potter, y'all should go look for that guy.
You know, we're going to move into more questions from the chat in about 1 minute. Did you have one, Mariana? You just have to unmute yourself.
Good thing I was muted because there was profanity again. I'm trying, guys. I'm really trying. So very quickly, just to tie in, when I was 6 months pregnant with my 4th child, I was not a public school teacher. I worked for a non-public school, so no union, employment at will, and really expensive health insurance. I was diagnosed with preeclampsia and antepartum depression, not postpartum depression. I got cripplingly depressed during the pregnancy, and I got very, very sick. And the school that I was teaching in was a non-public school. We had no union, and my principal was very upset that as a single parent, I was pregnant. She told me to have an abortion. I was outraged. And so then she would just do things to make my life difficult, like put a fake out of order sign on the elevator so that I couldn't take the elevator. And all of her, like, you know, malicious actions served to make my pregnancy even more difficult. It was already a high-risk pregnancy. And ultimately, she fired me. I was homesick. I was on bed rest. And I got a letter from my employer via FedEx, because we're employment at will. We don't have a contract. We don't have a union. And they terminated me retroactive to before the winter recess and canceled my health insurance for myself, my 3 children, and my unborn child during a high-risk pregnancy. They canceled it retroactively. They backdated my firing date to backdate before the 1st of the month so that I wouldn't have health insurance. So now here I was in the 3rd trimester of a high-risk pregnancy with no health insurance. And it took a month for me to get Medicaid, and my children, one of which we know has, you know, documented mental health issues and is classified special ed, it took almost 3 months for them to get Medicaid. So, you know, Medicaid is not the answer. We need coverage from womb to tomb that doesn't change with your partner, that doesn't change with your job. And so now let's switch gears. So thank you for letting me share that.
Mariana, I'm sorry to interrupt you. Your story is great and it's
You know,
important.
but I have a question.
Okay.
Yeah,
That's
so
my
we're
last
switching gears.
question.
This is a question from Kevin from Buffalo. He is with the Campaign for New York Health. And Kevin writes, he wanted to ask what the holdup is now to get the New York Health Act passed. Last election, we gained a Democratic majority in the New York Senate, So Dems have a majority in the Senate and the Assembly, and we have a Democratic governor who has said that if they pass it, I will sign it. So why are we still one senator shy? Jim Gordon, Todd Kaminsky, John Brooks, sorry, that's me. Damn cough. Who had said that we're still one senator short, even though the Dems gained 8 seats, enough is to easily get this passed and to the governor's desk. A friend of his has advised that just a few minutes ago, Cuomo was at a press conference this afternoon, and he says, how about we reimagine a New York with health care for all? So this is what Cuomo just said in his press conference, which, funny thing, this is what we've been asking Cuomo for all along. So in short, why aren't we getting the New York Health Act passed this legislative session, right? We have until June. Everybody's home. Let's get this shit done. I'm going to ask Gustavo Rivera, since you're in with them, to start off with the answer. Sorry to throw you under the bus. But these are your colleagues. Put them to work. Make them get their fucking job done. Sorry, I keep cursing. Okay, go ahead. Sorry, I'm muted.
Well, as far as like you asking me a question is not throwing me under the bus. Particularly if somebody doesn't like having tough questions asked of them, they shouldn't have this job. So let's just say that. So you're not throwing me under the bus. You're asking me a question that is the same question I ask every day. I would argue that, and I will continue making this argument to my colleagues, ultimately, this is something that needs to be achieved collectively, right? I can't do this by myself. If I was going to do this by myself, this shit would have already been passed. Sorry for the vulgarity. I know you'd appreciate that. But in all seriousness, so I have been pushing for this for the last couple of years. Certainly I believed in it for a while, but I've been the sponsor of it for about 3 years. So where we find ourselves in now is that we're one sponsor away from having the majority of the Senate on it. And prior to Corona, see, we will always refer to pre-Corona, post-Corona, right? So in the pre-Corona mentality, some of my colleagues argued that it was too difficult to do, that it would be expensive, that it would lead to new taxes. And it is complicated to do. It is expensive, but much less expensive than the current system because we save so much money, as I explained earlier. And it is something that would be complicated to do. But I would argue that this situation, this is what I'm trying to get my colleagues to understand, points out how, as I said earlier, how immediate the need is. So to answer your question, I'm going to try to push for it this year. Now, the governor, just to mention our visionary leader in the second floor. I don't know if you can tell, might be saying with tongue in cheek a little bit. I don't necessarily trust what he is actually saying. I know that's shocking. I know that people are a little bit beside themselves for me to say something like that. But when the governor says something, I do not take it at face value. And matter of fact, the fact that he is focusing now, he said that phrase out loud, would concern me, because that to me means that he is looking for an opportunity to make it his own, to be able to take credit for saying he is giving healthcare for all, while not actually getting the thing done. So trust me, my eyes are wide open with that regard. I know that ultimately we are going to have to negotiate with him to get a final package done. But what we demonstrated last year as a legislature with housing is that if we legislate during the budget, the powers of the governor are immense. And we could have a longer conversation about that because a bill was just introduced to change the New York State legislature, the New York State Constitution, to take power away from the governor during the budget. So we need to do that. But as it relates to the legislative session, we have the ability in a legislative session to negotiate amongst ourselves in the Assembly and the Senate and put a package together and then put it on his desk and dare him to veto it. So I certainly feel that we need to do that this year, and I'm going to push my colleagues. Now, I cannot speak for my colleagues. So if you're asking me why somebody who said that they were for it is not for it right now and is not on the bill, I can't answer that question. Y'all need to go ask that person, and you need to ask them again and again and again and again, because I only speak for myself. And as far as I'm concerned, this situation has shown more clearly than ever that this is not something that's just politically popular. It is an absolute human necessity.
Yes.
And I am going to push, I'm going to double and triple down on it. And those individuals who are not on it, they need to answer for themselves. They need to answer for their own actions. So I will continue to do that, and know this is the last word that I'm going to say on this at this point. I have been, every time that we have been meeting, since the Corona situation started. The first time that we had a conference that was a socially distanced conference. We usually meet in a big conference room, but we're sitting next to each other. So we started meeting in a hearing room where we could be 6 feet away from each other. And then we started meeting over Zoom. And every single time I've mentioned it, I've said, you don't want to hear it, but this is precisely why we need the New York Health Act. And I have been saying it over and over and over again, and I will continue to say it. So Mariana and to this gentleman, who, by the way, he also sent me a message over Facebook. I was gonna get to that question, but to answer your question, why have we not done it yet? Because some of my colleagues are resistant to it, and I'm saying that it is necessary to do it, is essential to do it, and I would ask every New Yorker to double down on their pressure on the folks who are not currently on it publicly.
Thank you, Senator. I want to work in one more question or two. We're getting close to the end of this program right now, and we have a few minutes of wrap-up stuff we want to do. But we have on the line Desiree Diorio. She's with NPR, and she wants to ask you some questions.
Hi, everyone. Can you hear me okay?
Yes.
More importantly, we can see the beautiful picture of whatever village that is.
Yes, that was from a trip from Italy quite a number of years ago. Thanks for doing this. Two-part question, I guess. Senator, it sounds like what you're saying is that possibly, I guess, a silver lining of the pandemic that we're dealing with right now is that the New York Health Act now has more support than it has before. First question, is that a fair characterization? Second part of my question has to do with long-term care. As you know, in New York, we're having a tremendous problem with nursing homes and the spread of the virus there. And my question is, what would the New York Health Act, in practice, after passed, what would that look like for our parents and our grandparents who are in nursing home settings right now? And thank you.
Of course. To first question, does it have more popularity? I think I wouldn't necessarily term it popularity. I would term it, at least some of my colleagues, clarity. There is, the notion that, and we already talked about it during this fight, the notion that a job would mean that you have access to healthcare, which is something that we've been saying forever, is just nuts. The fact that if you don't offer people universal coverage, you will obviously have to pay it one way or another. You'll have to pay for the fact that people are going to get sick because they're human. So all of these things, I would say, in the conversations that I've had privately with some people, some folks have been moved to understand the necessity of this. But ultimately the proof is in the pudding, right? As I stated earlier, and I will state it again, I only and will ever only speak for myself. I understand what my responsibility is and what my obligation is to all New Yorkers in my constituency. And so I know the stances that I'm taking to make sure that I defend their capacity to have access to universal health care. Anybody who is not doing that right now, and amongst all other times, they have to answer for themselves. And on the second part, as it relates to long-term care, look, one of the big issues here is that nursing homes and other long-term care facilities, but particularly nursing homes, have been underfunded for a very long time. And this is not a new issue. It comes up every budget cycle. For the last couple of years, partly at the, I'm not going to say insistence, but I am going to say at this administration has actually allowed for certain things to happen where nonprofit, privately held, but nonprofit nursing homes have actually not been able to maintain themselves, so they ultimately go belly up and are acquired by private for-profit nursing homes. And I'm not saying that for-profit nursing homes are a bad thing. Some of them provide great care, but as we said earlier, the idea that something that it would be that the market mentality will determine ultimately what you do is going to ultimately break down in a way, because that will mean profits over people's health. And so what it would mean if you had a system in which, first of all, long-term care would be covered. So you would have the sharing of the risk that we talked about earlier would actually make it easier for us to provide the services that are necessary for long-term care beneficiaries. The fact that we have primary care means that some individuals who wind up in long-term care would probably not need it, because they would actually have some conditions addressed before they get to the stage in which they require nursing home care. You would have the payment structure would be different. The reimbursements would actually correspond as per the state, as per the language in the bill, that they would correspond to the amount of money that it takes to actually provide the care. All of these things together would actually mean that the system would not be overtaxed like it is right now. So it is, right now we have, there's people who currently have to impoverish themselves to have Medicaid coverage for long-term care. How nuts is that? That somebody has to actually get rid of their wealth, which might not be that much to begin with, but they need to get rid of it to be able to be eligible to receive Medicaid. How is this a just system? So those are some of the things. And by the way, you should know that if you want to have a longer conversation about this, like we can always have a conversation elsewhere. I'm not hard to find. You can just go grivera@nysenate.gov and my communication staff will get back to you. So we can have the conversation later as well.
Thanks.
Thank you. We have to unfortunately wrap this up.
I'm sorry I went long.
No, you were great. And thank you all, panelists. Are you all available to answer some of the questions that are in chat after the fact?
Sure.
Okay,
Sure.
good. We'll forward them to you, and I'm hoping to post them on our website in the near future. I do want to go to Katie Robbins to kind of wrap things up, and I want to thank everybody for participating in this event, as well as the viewers, as well as the panelists. Thank you all. Go ahead, Katie.
Thank you so much. This was a really interesting discussion and a privilege to be with all of you today. And so here are the things we think we need to be doing to build the movement we need to get this across the finish line. I mentioned earlier the importance of sharing our personal stories. Making this personal and connecting to people across our differences is necessary for the movement we need to get the elected officials to do what we need them to do, which is pass the New York Health Act. We need elected officials to hear from you. So if you're listening now and you have not yet used our amazing tool, if you're looking at the website or the slideshow, you'll see there's a short link to NY Health Action. You can connect to your legislators using our tool that will, once you put in your address, you'll be able to email them, call them, and tweet at them, all in one simple action. We need as many people as possible to flood them with messages. And right now, unfortunately, we have less access to our legislators than we did before social distancing started. So leveraging social media is really, really critical. So we really need everybody to be jumping in, setting up Twitter accounts, sharing their stories online, and making it impossible for them to ignore the demand that we want the New York Health Act to pass this year. So you can also, there's other methods for how we tell our story. We're collecting videos, we're submitting letters to the editor, and there are 2 trainings coming up in the very near future. I thought the link was there. I'll just go ahead and pull up the details. If you go to our website, nyhcampaign.org, right on the events page, you'll see there's 2 trainings where you can dive in with us on how to tell your story effectively. One is coming up Monday, May 4th at 6 o'clock, and then Wednesday, May 6th at 11 a.m. These are great opportunities to connect with other like-minded activists and really develop this skill that we all need in order to build this movement. So I really hope people will participate and spread the word. For any questions that weren't answered, I want to point out that on our website, we have a really involved FAQ page because we've heard all the questions, I think. And we unpack a lot of them here. So I encourage people to check out the resources we have for learning about this issue and getting your questions answered. But don't stop there. Make sure you take this information out to your colleagues, to your friends, your family, to the networks that you're connected to, and make sure that your elected officials hear from you. The folks on Long Island who have not yet signed on, basically the only state senator who is on the bill is Senator Thomas. We are so grateful for his co-sponsorship, but that leaves work to do with Senator Gorin, Senator Brooks, Kaplan, Martinez, and Kaminsky. So we have our work cut out for us, but I know the Long Island activist is on the case. So join up with them in terms of local organizing on this issue. And I'm
so thankful that we got to have this conversation today at this important time in the campaign to win truly universal guaranteed healthcare in New York State. Thank you.
Thank you all.
All right, can I just add two things? There are some great documentaries that you can watch from home. We're going to post the links to those. Now is the time, right? And then help me because my brain is my blood pressure is
Really high right now, so I'm trying to relax because
that's a new skill that I'm working on developing, relaxing and breathing. But Katie, can you just shout out the names of the two documentaries right now, and then we'll post links for them.
I think she left already, Mariana.
She did? Okay, well, you guys know which
movies, but my brain is mushy right now, so you know, now is the time and the other one, but we'll post the link.
Mariana, are you thinking about Fix It?
Yes, yes.
Yep, that's what
Thank you. Yeah. But definitely, we'll drop links for those later.
Do any of you want to make any closing comments? We officially are ended, but we're still broadcasting.
Just thank you all for tuning in. Make sure you push.
We'll drop links for that too.
We can do this together. That's all I got.
Yeah, as much as I hate HRC, you know, the Stronger Together slogan,
you know, is more meaningful now than ever. We are stronger together. We need to be united. I don't give a shit if you're a Republican or a Democrat, if you're blue or red or green or libertarian or whatever. We need all of us to come together because healthcare is a human right, because our brothers and sisters are dying across Long Island, are dying in New York City, are dying throughout New York State, even before the COVID pandemic, but especially now during the COVID pandemic. So we need everybody to put aside all their petty political bullshit and work together as human beings to guarantee healthcare as a human right for every single person, first in New York State through the New York Health Act, and eventually across the country through Medicare for All. And I direct you to NYSNA, to National Nurses United, to the Democratic Socialists of America, to the Campaign for New York Health, to Physicians for a National Health Plan, Metro chapter or national, to HOPE, Health Over Profits for Everyone, and to the nurses unions and 1199 SEIU, not Long Island. Sorry, Luis, I love you, but you're not doing enough on Long Island. Because we need every single person together fighting. I am fighting every day to keep my blood pressure down, to stay out of the hospital so I don't have a stroke, so I can keep fighting for all of you. So even though Bernie dropped out, and you know, shout out, we got Cardboard Bernie hanging out with us. We need to be willing to fight for somebody we don't know. We need to be willing to fight for every single Long Islander and every single New Yorker to make sure that we all have health care, because we will die without it, period. And that's it. I'm done.
All right. On that note, thank you all. And we got to get this thing passed. She's so right. Bye.